Dr. Jacob Resch is originally from Spirit Lake, Iowa. Dr. Resch completed his undergraduate degrees in athletic training and health promotions and his MS degree in exercise and sport science at South Dakota State University. Jacob then pursued his PhD in exercise science at the University of Georgia, investigating measurement properties of current and novel measures of sport concussion. Following the completion of his doctorate, Jacob obtained an assistant professor position at the University of Texas at Arlington for 4 years, where he taught within the athletic training education program and conducted research addressing sport concussion in middle school, high school, and collegiate athletes. In the fall of 2014, Jacob and his wife Celestial and son Maxwell moved to Charlottesville, where he now serves as faculty in the University of Virginia Department of Kinesiology within the Curry School of Education, where he teaches within the graduate programs for athletic training and sports medicine and continues his research as part of the Brain Injury and Sports Concussion Institute. Jacob has presented his research at regional, national, and international sport conferences and has published in a variety of journals. And I'm now going to pass the control over to Dr. Resch so he can begin his presentation.
Evidence-based implementation of postural stability to assess sport concussion. My financial disclosures in terms of Pearson and 2 separate events in 2013 and 14. And lastly, of course, working with this webinar with NATIS. And thank you for allowing me to present to everyone today. So we were just covering the overview, looking at the incidence of sport concussion, and I was drawing attention to this table from the 2005 to 2006 sports seasons to the 2008-2009 sports seasons, and you can see a rough increase of about 2% of reported sport concussions. Now in 2008, the Zachary Lystedt law was passed, and it was the first law of its kind to start looking at the appropriate medical care provided to young athletes that have been diagnosed with a sport concussion. And you can see since the implementation of Zachary Lystedt law, or the law, since that time, several states have passed their own legislation. You can see that from 2008 to 2009, the number of concussions reported has increased by 11% compared to approximately 2% before the implementation of any concussion legislation such as that. And here's my case in point, looking at legislation that was started really in the state of Washington that has spread throughout the United States, and really every state now, with the last being Mississippi in 2014, has adopted some form of concussion legislation. And we've moved beyond the initial passing of a law to now revision of those laws, especially when we start looking at topics such as return to learn. When we break down that legislation, for the most part, every state has the same components to its law. So initially with education of the individuals surrounding the concussed athlete, to removal from play for an athlete suspected of having a concussion. And then where we start seeing the most discrepancy is between who can clear the athlete to return to play. Is it a specific healthcare provider, as noted by the asterisk at the bottom of the screen, or is it a healthcare provider in general? So that is where I think a lot of revisions are starting to take place in terms of the current concussion laws, is to make each law more specific to clearance, but also return to learn. There was one state that was an outlier, and that was the state of Arkansas in terms of their concussion bill, which suggested that they were dedicating $1 million to study sport concussion, but none of the other components of the law were incorporated into the bill as it stands. One thing I wanted to really stress, and this is really important for the majority of the attendees today, is that sport concussion makes up a small percentage of the injuries that are diagnosed with concussions. So if we look at this, being struck by or against something in 2006, and this is based on the landmark study that individuals quote as the 3.8 million concussions occurring each year, 19% of emergency department visits were diagnosed as sport concussions, but for that time, they're categorized as being struck by or against something. A more recent emergency department study found that sport was not the number 3 cause of concussions, rather it was the number 1 cause, which took priority over motor vehicle accidents and falls. One thing that I think that we should highlight here is even though it's the #1 cause of emergency department visits for concussions, you still look at it being a smaller section of the total concussions that visit the emergency department. And unfortunately, concussions or traumatic brain injury in general occur from motor vehicle accidents, falls, assaults, and then other mechanisms as you see by this slide. Now let's talk about balance and sport concussions influence. So if we look at the way that has been recommended since 1997 in terms of concussion management, it's a multidimensional approach. And this approach has been shown to have the least amount of error correctly classifying an individual as concussed when they're concussed. So to complement the clinical examination, we have the computerized neurocognitive testing, we have balance testing, and we have symptom assessment. So the focus of today's talk is, of course, balance and for concussion, but let's not forget the other pieces of the puzzle that go with the injury. So to define an important concept for this talk is evidence-based practice. So to operationalize this definition, it's combining the best research evidence that currently exists with the clinical expertise that you all possess in order to improve patient outcomes. One thing evidence-based practice is it's not a blueprint. As evidence continually is introduced to the literature, it's important that we continue to refine our practice in order to reflect the best evidence that's out there and really to ask ourselves a question. Although the study was published, does this really mean anything to my clinical practice or not? So that's where the blueprint comes in. There's no such thing as a blueprint. Rather, we need to be the clinical experts that we are and say, does this clinically make sense in order to improve our patient outcomes? So for the evidence that exists in regards to balance, and I realize that this might be a refresher for some of those that are listening today, but others this might be brand new. We look at posture control in terms of 3 sensory inputs: sensory through proprioception, visual input, as well as vestibular input, which are combined that allow us to integrate those sensory inputs into the brain and allow us to balance through ascending but also descending pathways, which then interact with the skeletal muscle. Following concussion, we know that this integration of these sensory inputs are disrupted, but it's not necessarily the sensory input, specifically the smell sensory, the visual, or vestibular input that's disrupted, although it can be. It's rather the interaction of those inputs in specifically the midbrain or to the thalamus. And what we see is with these balance disruptions is they are transient. So a majority of individuals, so 90% of individuals will have their balance regained within 3 to 10 days. Now, this, of course, there are the individuals that take longer. But if we look at the types of testing measures that are used, if we look at if we're dealing with an adolescent versus an adult athlete, those timeframes can vary, which match up pretty well with what we understand from the physiology of sport concussion, which was introduced by Chris Giza back in 2004. But if we talk solely about those sensory inputs, of course, that's only providing a small picture of how we can control our balance or balance control, looking at biomechanical constraints, movement strategies, cognitive processing, and so on. So balance, of course, is much more complicated than what was summarized on the previous slides, but for today's talk, it does a nice job of discussing what we're trying to measure and how we're measuring balance following for concussion. So here's one example of the test I noted on a prior slide, and that's the sensory organization test. For the sensory organization test, it's looking at specifically the smell, sensory, vestibular, and visual inputs in isolation from one another, but also in combination with one another based on way as measured by center of gravity. So for the sensory organization test, if you're not familiar with it, individuals are placed on a dynamic system, which for condition 1, if you can see my mouse, you can see we have an individual that's on a static plate with a static background with their eyes open. And just to give you an idea on how we can manipulate sensory inputs, we simply have an individual in the same condition close their eyes. That is minimal perturbations to balance, and then the system can get as complex as having the individual's visual input with way reference, surround, and support. Now, the individual completes 18 trials. Each trial is 20 seconds, which then derives a composite balance score and the three sensory ratios being somatosensory, visual, and vestibular sensory ratios. Here's how it looks, or those scores look following a concussion. So here we have two groups. We have an injured and we have a control group. And here's prior to injury. So on the top we have our control group, so those individuals that are non-injured, and this was published by Connie Peterson back in 2003. And the bottom here with the diamond, we have those that just sustained a concussion. As you can see, we have a significant change in balance performance as determined by the SOT, or Sensory Organization Test Composite Score, immediately following injury, so within 24 hours of the injury. By day 3, those scores normalize to pre-injury values and slightly increase by day 5. One thing that I'm going to note is we do start seeing a significant increase in performance for those that are exposed to the test over serial time points. And we're going to talk about that being something we have to take into consideration as we administer this test to our patients. Now, a more cost-effective measure that was developed out of UNC Chapel Hill was the Balance Area Scoring System. And the Balance Area Scoring System was created as a concurrent validity study. So taking a gold standard such as the SOT in terms of postural stability and trying to find a more quick and time and cost-effective measure. So what the best consists of is individuals taking 3 stances, so a double leg stance, a single leg stance, and a tandem stance on a firm surface, but then again on a foam surface. And the clinician is to count errors that the individual commits while trying to maintain positions with their hands on their hips and their eyes closed. And you can see the errors on this slide. Now, what Natus did was they tried to, it was a really interesting product. They tried to go back in time and recreate the same methodology that created the best. And how was the best created? They basically put the foam pad on a force plate, looked at sway, and compared that sway to what's picked up by the more sophisticated sensory organization test, and that's termed concurrent validity. So, though that study was done in like 1998, 1999, 2000, what Natus has now produced is VSR Sport, which basically looks like how the best was created, except we're not counting errors with the VSR Sport, rather we're looking at sway velocity, but you can see the force plate sitting underneath the foam pad, which makes it a more objective test, and we're going to be talking about that in later slides. So what does the error count? So the number of times an individual breaks out of a set position look like pre-injury, but also 24 hours after the injury. As you can see here, there's a significant increase in errors. So errors are things that were noted on the prior slide that individual commit while trying to maintain a particular position. By day 3, you can notice that the errors go back down to pre-injury levels. Again, if you look at controls, in this study, you can see that the errors committed are relatively the same. There's no significant change between baseline days 1, 3, and 5. But we do see that significant increase following injury using the best. What about the best in terms of errors of gender? I basically manipulated some data to create this graph from Tracy Gavassin, a very well-done study that was published in 2012. And what I wanted to show here is this is day 1 post-injury for males and females. So males are the solid line, females are the dashed line. And what you can see here is a significant decrease between day 1 and days 2 and 3, and again from day 2 to day 3 for the errors committed to the best. So one thing I want to note here is there was no gender difference. So between the 2 genders and both college and high school athletes, there was no significant effect in terms of gender with the balance error scoring system tracking errors as an individual recovers from their sport concussion. And to further support this notion, Cibrolio conducted a meta-analysis on 6 studies, which is a relatively small amount of studies, but a meta-analysis, believe it or not, can be published with 1 study. And with these 6 studies, he found a large effect size that showed that balance was involved during the initial assessment following concussion. and there were significant differences following the injury, but also, again, a follow-up. And what's interesting to note at follow-up is these studies looked at balance and services up to 14 days following injury. So, again, another large effect size saying, yes, balance is a key factor in looking at sport concussion. That said, with every study that I mentioned thus far, and we're going to go into some more current literature here in a few slides, future research is needed, and specifically in terms of the evidence base surrounding current measures of balance. So if we look at measurement properties, I'm going to be talking about three: objectivity, reliability, and validity. So to start off talking about objectivity, let's say that I had a test, let's say it's a VSR Sport, and one of you administered the VSR Sport, the stability evaluation test, to the same athlete. So you and I were administering the same test to the same athlete. If the wave velocity as measured by the VSR Sport, or for another test, the best, the number of errors that you count and I count for the best test, or the balance error scoring system, are the same, we would say that test has a high level of inter-rater reliability, or how consistently are the raters evaluating or scoring the test. So once we have an objective test, we can move to collecting evidence of reliability. So specifically to this study, we're going to talk about test-retest reliability. So that's the consistency across time of performance of an individual taking the test. So again, taking into account the VSR Sport or the balance error scoring system, how consistently do those individuals perform on the test when they're healthy in order to say, yes, it's the concussion affecting their balance opposed to other sources of error. So if we have low test-retest reliability, we would say that it's really difficult for us to say, is it the concussion affecting balance or is it error associated with performing the test? And last is validity. So I've already talked about one type of validity, and that's concurrent validity. So again, it was when Kevin Guskowitz and Ryman created the best that they compared a more quick and cost-effective measure of balance to a gold standard, and that's the sensory organization test. So by comparing those two, that's a form of concurrent validity. The other validity that I'm going to be talking about more extensively today is sensitivity and specificity. So sensitivity is correctly classifying an athlete as concussed when concussed. And specificity for today's talk is going to be defined as correctly classifying a healthy individual as healthy when they are healthy. In order to collect this evidence of validity, first we need to obtain objectivity and reliability evidence. From there, we can go forth and collect our evidence of validity. So again, in specificity, one concept we're going to be talking about a little bit more today is reliability. So the consistency of performance across time for an individual. Here's an example I like to use to demonstrate reliability. Let's say that one of my students here at University of Virginia came in and they took one of my tests, and that test had a reliability of 0.9. So here on the x-axis we have reliability, which ranges from 0 to 1. We want values closer to 1. And with that 0.9, then I administer that same test the following week to the same individual, and their score, if the test has a reliability of 0.9, can range anywhere from an 87 to a 93. Regardless that they scored a 90 in the first time they took the test. Now let's reduce the reliability of that measure from a 0.9 to a 0.75. The next time the individual that would originally score a 90 on the test and they came in a week later and they took the test again, they would score anywhere from an 84 to a 97. So if you could imagine reliability dropping, you can imagine the fluctuation in scores of a particular test, whether it's balance or cognition, etc., how they would increase, making it a less reliable test. So to apply these concepts, we have to think about what we used to use in order to assess balance, and some individuals are still using this test as a silent test, the Romberg test, to what we're using today. So balance products have been produced and introduced to the marketplace in a dramatic fashion over the last decade in response to the sport concussion, media awareness, parent awareness, athlete awareness. And I think it's great to have this variety, but one of the questions that we need to have going into the marketplace is saying, what is the evidence of objectivity? What is the evidence of reliability? And what is the evidence that exists for validity? So if we we look at this table, what I've done is I compiled the evidence of current measures of balance that I recently saw at the National Athletic Trainers Association Clinical Expo during their annual meeting. And on the left here, we have the program or device, so ranging from the sensory organization test all the way down to using the Nintendo Wii Fit. The next column represents the time interval, and this is in terms of reliability. So what were the time points used to administer the test? Was it 2 days? So the test was administered at day 1 and then 24 hours later? Or was it 1 month? So day 1 and day 30, or 1 week, day 1 and day 7. So please look at this column in that context. Next to that is the reliability coefficient. So reliability can be looked at as a Pearson's correlation coefficient, which does not take into account the error associated with time that elapses from time 1 to time 2, but also through interclass correlation coefficient. This is the preferred methodology for looking at reliability, and both are interpreted the same, ranging on a scale from 0 to 1, 0 being no reliability to 1 being perfectly consistent across time. You can see that the evidence for the sensory organization test, the VSR Sport, and the balance error scoring system ranges. And it ranges from weak to strong. And it really depends on the methodology of how this test or these tests were assessed. The other thing I want you to realize is that there are tests on the market that don't have evidence of reliability. And I think that we have to be smart consumers, especially in the clinic or in the hospital, in the athletic training room, and make wise decisions about not only purchasing this equipment, but also deciding, are we going to incorporate this into our concussion management protocol or not? So if we look at the validity evidence, and specifically sensitivity and specificity, so again, sensitivity, the ability for the test to accurately depict a concussed individual as concussed, and specificity, the ability to detect a healthy individual and classify them as being healthy. These values, again, range from 0 to 100%, and we want the higher values for each. And you can see, again, the sensitivity ranges. So whether the test was administered at 24 hours following injury or over 2 or 3 days, as we know that now that balance starts to go back to pre-injury levels around day 3 all the way to day 10. And you can see relatively high specificity for the sensory organization test, as well as the balance error scoring system, and a lower sensitivity for the balance error scoring system. And one thing that's important to note here is with the VSR Sport, though it's lacking in published sensitivity and specificity evidence, if you were to count the errors that are associated with an individual completing the VSR Sports stability evaluation test, I would recommend that that would be very similar to incorporating the balance error scoring system into your protocol, while also collecting splay velocity, which is measured in degrees per second. But as you can also see, there are other products in the marketplace, and Nintendo is unique because Nintendo takes a firm stance saying that we are not creating a healthcare product, we're creating an entertainment product. So the company itself isn't necessarily interested in that evidence being published. So please take that with a grain of salt, although it would be interesting to start seeing sensitivity and specificity of the Nintendo Wii's balance platform being introduced to the literature. So that's the evidence supporting balance measures as they currently exist in the marketplace. So if we look at evidence-based implementations, one thing to select the product that you want to incorporate into your clinic, but the other factors, the other error, extraneous error that can influence balance performance that we need to be aware of. And I heard it suggested very succinctly that you basically get out what you put in. And I think balance is a true representation of that in terms of making sure the environment is conducive and the athlete is conducive to trying to reduce the error associated with testing. So of the sources of error that come into play, especially when you're looking at a pre-injury evaluation or a baseline test, and in this case also removing an athlete from play and looking at doing a BAS test, VSR Sport test, or one of the other portable force plate systems that are on the market, we see that fatigue is a factor. And in fact, in 2004, this was first published showing that if you have an individual that rests immediately after completing, I believe it was 65% to 70% of their target heart rate, immediately have them do the best, there's a significant amount increase in the number of errors committed on the best test. Keep in mind, this is bad. This might be showing that there is a false positive. In reality, it's more or less due to fatigue rather than the true ability of the athlete to balance. And I apologize, I'm not being arrested now. That was just a cop car going outside my window. Now, as far as fatigue's role in balance beyond initial removal from play, if you're able to hold that athlete out for 13 to 15 minutes, you're going to reduce the effect of the number of errors that are associated with fatigue. So, for instance, with the University of Virginia, for our protocol, we're going through some of our baseline assessments now. If an athlete finishes strength and conditioning and they want to complete their balance assessment, we actually have them wait 15 minutes for the balance test, and we have them wait approximately 2 hours for a cognitive test to avoid any additional errors that fatigue or hormonal fluctuations may have on balance performance. One thing that was interesting is dehydration did not play a role in balance performance using a sophisticated measure such as the SOT. Specifically, as I noted here, this group of researchers had roughly a 2% decrease in body weight as a measure of dehydration, which has been known to affect cognitive ability, but they found no difference in hydrated state versus a dehydrated state in terms of balance performance. So although fatigue is a factor, dehydration, though we don't want our athletes to be dehydrated, does not play a role in balance performance. What about test-retest reliability? The overall best, so when I say the overall best, using all 6 conditions, so the double leg, single leg, and the tandem stance on the firm and foam surfaces, has been shown to have moderate, good test-retest reliability. So starting at 0.6, and I believe the highest value that's been reported is a 0.74. Now, the modified best was introduced in 2008 with the 2008 Zurich document, which incorporates solely the firm surface. Thus far, there has been no evidence solely on the firm surface in terms of test-retest reliability or sensitivity and specificity. So I think that's an area of research that we need to dive into to say, for the SCAT2 and SCAT3, those are using that test, should we do all 6 conditions or should we just do 3 conditions? For the research that is out there regarding the test reliability and how to improve reliability of the best, a study was published by Hunt in 2009 that found that the reliability of the best was 0.6 specific to that study, but when you remove the firm double leg and firm foam stances, you can actually improve the reliability from a 0.6 to a 0.7. So remember, it doesn't seem like much, but we're reducing the error around the performance from one point to the next point for an individual completing that particular test. So if you're looking at incorporating the best into your clinical practice, I would encourage you to take a look at removing the double leg firm and foam surfaces as a form of modified best to save on time, but also to increase reliability. What about inter-rater reliability? So increasing the objectivity of the test. So inter-rater reliability has ranged anywhere from 0.61 to 0.96 in the literature. Again, depending on how many raters were involved and the methodology in order to calculate inter-rater reliability. And you don't, as a clinician, you don't need to calculate an inter-class correlation coefficient in order to improve reliability. Inter-rater reliability with a particular best, such as VSR Sport, the best, the SMT, or what have you. But what you can do is standardize your raters, or standardize the individuals, your athletic trainers, the other physical therapists that are using this test by simply recording an individual performing the test, as we've done here, and basically have everyone in silence record the number of errors that they see the individual commit, or talk about the methodology and how to employ the test to say, well, what would we do differently, or is this the appropriate way to administer this test or not, and simply have a discussion afterwards. It's a very simple technique that would increase the consistency of raters that are administering these tests that we know that there is an issue with consistency, both inter-rater and retest reliability, and make it a more reliable test, making subsequently a potentially more valid test. What about practice effects? Practice effects have been noted in both systems. From the BESS, the Balanced Error Scoring System, the VSR Sport has also been noted to have practice effects. The SOT has practice effects. Simply, people get better at taking the test. And here are my remedies for that, and it makes perfect clinical sense. Administer practice trials. So with the Balanced Error Scoring System, you can administer and for the VSR Sport, you can do one full administration of the test and then have the individual complete the test again right away. We did this at a local private high school, and the Balanced Error Scoring System and the VSR Sport were being used. It took 4 minutes to administer the first test, and it took an additional 4 minutes to administer the second test. So instead of a 4-minute administration, it was 8 minutes. But we were able to achieve a more stable score. The other thing that is probably more pertinent to the sensory organization test is to randomize trials opposed to doing a serial administration. And here, in a study that we're prepping to publish right now, we increased the reliability of the sensory organization test, looking at solely the composite score from a 0.86 to 0.90, so really a relatively high amount of reliability when comparing to the serial administration of 0.78 to 0.85. Again, you're probably thinking this isn't not much of a change, but again, we're controlling for the additional error. So if we can control for additional error by simply using a computer-generated series of random numbers in order to administer the test, then that's going to give us a more reliable test, and again, subsequently a more valid test. So here's an example of the Balanced Error Scoring System, again with the practice effects, looking at the pre-injury level in healthy participants. So the baseline level, 3 days following the injury, there was not a significant change, but then we have a reduction in errors, a significant reduction in errors compared to baseline on the 3rd delivery and the 4th delivery of the test. But here is our study that we currently have in preparation, and I like this design because the sensory organization test is a relatively novel task for an individual to complete. We did a full administration of the test on day 1. We had individuals come back at day 2, so 24 hours after day 1, and we started experimenting with the individual. And individuals were basically given serial administration of the test or a random administration of the trials, and we had a 15-minute rest in between, so that the sensory organization test takes approximately 12 to 15 minutes to complete. We gave the individual 15 minutes to sit down in a chair and relax, and then we administered the following administration of the test with the opposite order. So if they received serial first, they received random second. This was a counterbalance design, so at day 45, if they received the serial administration first at day 2, they then received the random administration first on day 45, and then again at day 50, they received the opposite order. And what we found were practice effects between that day 1, although we were just collecting it, that information just as, I wouldn't say on purpose, rather it was just a time to orientate the individual to the test. So although our methodology was standardized, we weren't expecting to do much with that data. But what we did find was that there was a significant improvement in performance at day 2, but then there was not a significant performance from day 2 to day 45, and then there was a significant improvement in performance again at day 50. So the 4th administration of the SOT led to a significant improvement over day 2 and day 45, which brings up another point. How often should we administer this test? Do we really need that data point immediately after the injury, or can we administer the test to get a more reliable result if we do a pre-injury assessment followed by when the athlete reports symptom-free? So that would potentially lead to less practice effects associated with the SOT. And here's my box. I should have highlighted this difference a little bit earlier, but what I'm trying to get at here is after doing a practice SOT, scores stabilize between the 2nd and 3rd delivery. What about the environment? In the clinic, I realize it's difficult to isolate individuals doing a balance test, especially if you have a relatively busy clinic. But it's something that we know that we need to do, especially if we're using tests like the bouncer scoring system, or as I mentioned earlier, if you're using the bouncer scoring system, if you place a force plate underneath it, you have the VSR Sport looking at slave velocity. The environment's important to control. A study that was just published on that individuals that completed a task in an environment full of distractions, so a sideline of a basketball competition or a football competition, committed significantly more errors than those individuals in a more controlled setting. So here's my example of a live sporting event versus no event. So you can see on a sideline of a football game, probably not in your best interest or the athlete's best interest to assess balance. Rather, get them to a quiet, controlled environment like the athletic training room or a locker room where balance can be assessed after not only they're removed from environment full of distractions, but also which would give them the ability to recover from the exertion they just got done doing. So to conclude, keep in mind that balance is only one component of this multi-dimensional approach to concussion management. And in fact, the sensitivity of balance following concussion has been noted to be anywhere from 60% or slightly higher. And it's not balance in isolation that we would administer solely to look at concussion. It's how it compares to results from our cognitive testing, our symptom checklists, our scales, and then of course our clinical examination, and how we combine both the clinical expertise along with the best research evidence in order to create our concussion management protocol. Now, as I mentioned, the prior slide, that information has been recommended and researched since 1997. In 2005, a survey was done of the current practice of athlete trainers who, in my opinion, are on the front lines of concussion management simply because they're on the field. They're most likely going to be there at the time of the injury and facilitating management thereafter. So you have, in 2005, a survey completed. This is right after the NATA's position statement on concussion management was released. And roughly 3% of athlete trainers were incorporating the multidimensional approach to concussion management. In 2013, a study by Weinall out of UNC Chapel Hill found that 21% of athlete trainers were using the recommended approach to concussion management. So even though there has been an increase in the use of this multidimensional approach, incorporating balance, cognition, symptom checklists, and the clinical examination, we still have a long way to go. And this is not to throw, by any means, athlete trainers under the bus, but when it comes down to it, it's a lack of resources in terms of budget, but also time and personnel in order to facilitate testing of a large number of athletes. I'm working with a local private school now that we're baseline testing their athletes, approximately 200 athletes. That's a lot different from my experience working with a school that had 2,300 athletes in Texas. So again, it's a resource issue. Now, to be fair, the private school here has one full-time athletic trainer and 2 graduate assistants helping that athletic trainer. The school in Texas had 4 full-time athletic trainers, but still, with 2,300 athletes, that's a large amount of athletes to baseline test. Now, if you look at the incorporation of balance of surveyed athlete trainers, and to be consistent, I looked at the surveys in terms of the balance error scoring system. The other specialized balance measure that was discussed was the Romberg test. Unfortunately, in terms of concussion, the Romberg test has little to no evidence to support its use in order to assess concussion. And really, it's such a gross measure of balance. It might be an effective screening tool, but still, there's no evidence to support its use. But there is evidence in other conditions, such as Parkinson's, and of course, more significant brain injuries / conditions. And what we can look at with balance is, in 2001, a survey was done looking at approximately 4% of athlete trainers that incorporated the balance error scoring system into their practice to assess balance following concussion, followed by an increase of 15% in 2005 and roughly 25 to 26% in 2013. So again, we're slowly incorporating balance into standardized concussion management protocol. And in terms of who's caring for these athletes, and I realize that we have a variety of healthcare professionals on this call today, and I'm really excited about that because I think concussion is not something one healthcare professional is going to solve alone. The issue is not only a multifaceted issue that we have to take into account several dimensions, but we have to look at several work, especially to assist the athlete with a protracted or prolonged recovery, depending on how you define that. That could be 14 days, 19 days, 21 days, 30 days, depending on what literature you're reading. But you can see a majority of individuals that are working with concussions right now range from the certified athletic trainer. And if you take into these 4 columns, of course, that makes more than 100% just report taking into account 4 different professions. But please keep in mind, it's these individuals working together that are being counted twice. So this value is going to be well beyond 100%. But it's that interdisciplinary approach that's so important, especially with state laws, some of them requiring specific healthcare providers to provide clearance for an athlete to return to play. So to really summarize the talk, with balance assessment, we've discussed or have highlighted some components of reliability, sensitivity, and specificity showing that balance is not perfect. What we currently have is not perfect in order to assess balance following concussion, but it's the best of what we have. So the questions that I encourage you all to inquire about, especially at your annual meetings when there's clinical expos or you have someone doing a presentation to you about how you should incorporate their product into your balance strategy, is simply ask them, do you have evidence of objectivity? Do you have evidence of reliability? And do you have evidence of validity? And please use this presentation to facilitate that conversation. And of course, I'm always willing to field questions about this after this discussion, but I do think that we need to be smart consumers when it comes to deciding how our money is going to be spent, but also, more importantly, how are we going to best care for our athletes? How do we detect subtle differences in balance or cognition or symptoms following injury? And these questions are a great start to facilitate that question, facilitate that conversation. And on top of that, and I hate to be the bad guy here, but at the same time, if there is no published evidence, and there's a difference between published evidence and data that we have. One of the things I do at our annual meeting is I go around to the different vendors and I ask, do you have any evidence to support the use of this product? And one of the common responses I get is, yes, we have, we've collected 3,000 baselines, or we have this data. The next question you need to ask is, great, is it published? Because it's one thing to collect the data, but it's another to go through the peer review process and say, is this data valuable in order to make inferences about objectivity, reliability, validity, or do you simply need to wait a little bit for that data to be published in order to make that purchase decision? This was another piece that came from presenting on a very similar topic in El Paso, Texas. I left the presentation, and one of the questions I received was, this is great information, but what does this mean to us as a group of athletic trainers, nurses, physical therapists? And what I came up with was this slide that I need to have modified a little bit. I apologize for the prices. I'll try to correct for here shortly. But let's say that you're an athletic trainer and you have a limited budget, so $5,000, versus someone that with a clinic with a slightly larger budget, versus someone in an academic institution that, for instance, we have a Neurocom Smart Balance Master, but we also have a Vertec Dynamic System, which are valued well over $300,000 together, not separately. What I did is I looked at the multidimensional approach and I looked at the evidence and asked, what would be the different combinations of these instruments that would help a clinician implement a multifaceted approach to concussion management. And for the inexpensive route, the evidence is out there looking at the SCAT3, not the SCAT3 as a whole, but the different components of the SCAT3 that are evidence-based, the balance error scoring system, some form of symptom checklist. I'm not too skeptical of one checklist or another. It's just you're looking at the symptoms. And the cost for 200 athletes would be about $90 with the actual approximate time frame of 20 minutes per athlete to do that baseline. For a moderate package, you can incorporate computerized neurocognitive testing, a computerized measure of sway, such as a VSR Sport or the Vertec Sport Advantage, or TechScan has a product out now, symptom scale, and that would range. Actually, this is an underestimate, but it's approximately $12,000 to $15,000 depending on what balance platform you want to use. And then lastly, we have really the Porsche model. So not only do we have the computerized neurocognitive test, but potentially we have a neuropsychologist working with our sport management program. We have a sophisticated measure of balance the dynamic systems that I mentioned previously, a checklist, which totals just over $100,000. And with the increasing price, we also have the increase in time. So 40 minutes, mainly due to this being a computerized neurocognitive test that's administered versus a SCAT-3. And then if we go to the Porsche model, we have the increased time with administration of the balance test as well as the computerized test. So last but not least, I want to talk about what do you do with this information once you pick your balance measures, your cognitive measures, symptom measures, and you want to develop a concussion management protocol. It needs to be committed to writing. It needs to be discussed. It needs to be revised with the emerging evidence that's out there. Not only that, it needs to be venue specific. I led a team of graduate students that assisted in developing emergency action plans for Tarrant County. Their parks and recreation facilities host over 500,000 athletes per year, and none of those facilities had an emergency action plan in case something did happen to one of those athletes. So we took it upon ourselves in order to develop those protocols for them. The one thing that I thought was a valuable lesson for a student to realize was, well, on the top we have a picture of a field that sees quite a bit of activity that required an emergency action plan. On the bottom right here, we have Scott Stadium at the University of Virginia. Depending on how you create your concussion management protocol, you need to take into account the facilities that you have. How are you best going to implement your protocol on the field or in the clinic or in a stadium such as Scott Stadium? And you need to distribute this information amongst your coaches, your administrators, the parents, so everyone's on the same page, including the athletes, so they understand, well, you're not trying to hold my athlete out for a prolonged period of time because you're not sure, but here's what the evidence suggests when you take this multidimensional approach. And by the way, we can't do this test on the sideline. We need to wait until the athlete's in a quiet environment in order to do this test and they've been well rested. And with this plan, you have to rehearse annually. We have to revise and not only say what worked and what didn't work. And with what worked and what didn't work, here's a prime example of that. Red shirt freshman. And this is and I will try to turn the sound down here. Chris Dodd with an excellent quote. Ron Corson is one of my mentors that I had during my doctoral work at the University of Georgia. And, you know, one of the things I respect about Ron is he does things extremely well, and his team is second to none when it comes to emergency management of injuries. But with this particular injury, one of the things that really stuck with me as a student, but now as a clinician and researcher, was despite their excellence in healthcare at the University of Georgia, one of the things that he called the next day was a meeting. Why? To discuss this. It takes approximately 8 individuals to spine board an athlete, and here you see on the lines of around 12. Ron called a meeting in order to say, what can we do better next time? And I think this is a really strong take-home point about the sports medicine team, the concussion management plan, is to say, yes, we did spine board the athlete in a very short amount of time, but we had too many people on the field. So even though it's done really well, and the concussion management protocol is just part of that, you know, you can have the best management protocol that exists, but you always have to continue to revise and rehearse and update with evidence-based practice. So to conclude, so regardless of state legislation, and this is my own personal stance, this isn't the opinion of NATIS or anyone else, state laws are wonderful, but as healthcare professionals, we do need to take the leadership role in our communities in order to implement a multi-dimensional evidence-based management protocol for sport concussion. In terms of the sideline or concussion management plan following injury and even before injury, that plan needs to be discussed and distributed amongst members of the sports medicine team, especially if you're adopting balance into your protocol to say, what is the best way to implement this timing-wise? Do we do baseline? Do we not do baseline? Do we administer this in the office? If so, where? What does post-injury evaluation look like for a concussed athlete? Concussion protocols also need to be continually revised and discussed, especially with the copious amounts of evidence that's being produced right now and published in order to better care for concussed athletes. And finally, as represented on this webinar today, concussion management protocol is not only a multidimensional approach, but we need to work together and it needs to be an interdisciplinary approach to best care for these young athletes. So with that, I want to thank you very much for your attention, and I apologize again for the technical difficulties, but hopefully now we have some time for some questions.
Thank you, Dr. Resch, for this interesting presentation. This recorded presentation is available online along with previously recorded e-seminars. Click on Live Events to register for upcoming e-seminars throughout 2015. Visit nervecenter.natus.com.